Next week, Top Med Talk is live at Anaesthesia 2019. Experts from around the world with the latest advances in anaesthesia, pain and perioperative medicine help to shape the future of the specialty in the UK and beyond. Go to topmedtalk.com and check out the show notes to this podcast. Limited places remaining on Wednesday the 22nd of May to Anaesthesia 2019. Go to www.topmedtalk.com.
Top Med Talk.
This piece is taken from the Perioperative Medicine Shared Interest Group's 2018 annual conference, Measuring, Managing and Minimising Risk, which was held in association with the Australian and New Zealand Society of Geriatric Medicine and the Internal Medicine Society of Australia and New Zealand. Don't forget to check out the show notes on topmedtalk.com for more details. Have a listen.
So my name's Debra Leung. I'm a staff anaesthetist for MacCallum, and what I want to do is take it a step forward to the point where you see a patient and all of the systems and the processes have failed to happen. And I think all of us have seen a situation where we think, how come I'm the first person, whether you be the anaesthetist, the physician, the geriatrician, the intensivist, whatever your background in clinical medicine may be, where you've seen a patient where you think, this conversation hasn't been had and it should have had prior to that. So in healthcare, we have 11 organ systems, and for these 11 organ systems, we have 60,000 medical diagnoses and counting. And for these 60,000 diagnoses, we have now managed to generate over 4,000 surgical procedures that we can do to treat these conditions. And you can see that we are literally drowning in the complexity of the last century of medical discoveries. And the challenge that we face now as medical professionals is that the realm of things that we can do is ever expanding, but what hasn't caught up from an individual and a systems level is for us to align what we can do with what we should be doing. I don't have to tell any of you that we have an ageing population, so we know that in the year 2044 there are going to be 15 times more people who are aged over 85 compared to in 1984. And I think you've been banged over the head with it over the last sort of year or so of perioperative medicine to know that these patients do badly. Okay, all of the advances in perioperative medicine, prehabilitation, post-operative care, despite those things, we know that these patients have a very, very high risk of post-operative morbidity and mortality. And because of the inherent frailty, medical comorbidities and the high-risk procedures that we're exposing to, only a certain proportion of that is modifiable. So we are going to be seeing these older, sicker patients coming to a theatre near you. This is only compounded by the fact that we are doing an exponential amount more surgery, and this is in the developing world as well as in the developed world. And you'll see that in the developed world, we're obviously exceeding our partners in the developing world. So these patients are only going to be increasing in their frequency. And the problem is now that this is our traditional model of medical decision-making, and it's a very, very good model. It's served us well over the last 50 years or so. And for most of our patients, they'll proceed through this without any sort of particular difficulty. The problem is now for those frailer and older and sicker patients, we're seeing them now fall into this hole. So where they get complications after their surgery, they return to theatre, and how long they cycle around this sort of cycle of complications, we don't really know. And the last day or so, if you've been here, we've been talking a lot about the perioperative medicine team, which is an excellent advance and has really revolutionised care. And you can see here that there's a lot of input from multiple specialties, and all of these people are essential to a good perioperative team. But although you'll see a lot of names here, the one name that you'll see is missing is the patient. There's no patient in any of this. There's specialties from every single area, but there's no patient. And this is really where shared decision-making can offer us a framework to involve patients as equal partners in decisions made about their healthcare. So this is a definition of shared decision-making. There's a number of policy papers out there that talk about shared decision-making, and there's a lot of words here. I've tried to highlight the important ones in red here, and this is taken from the King's Fund policy paper, which is a very good paper. The reference is just down the bottom if you ever feel the need to look it up. And it's a UK-based paper that sort of tried to summarise what we know about shared decision-making so far and what the possible future directions might be. And I've put it up here really not so that you have to read it verbatim, but to point out to you that shared decision-making, although is discussed a lot, but it's always discussed as this nebulous concept, like we should do shared decision-making. Shared decision-making should happen. We should have patient-based discussions. We should have patient-based conversations. But nobody actually teaches you how to do it. And we come away with this sort of groundswell of enthusiasm for shared decision-making. And then when we get a patient in the perioperative clinic or for the emergency laparotomy at 2 o'clock in the morning and we think this needs to happen, we don't have the skills or the abilities or the practical foundation to actually do it. And so that's what I'm hoping to share with you today, is how can you bring it from this nebulous concept and demystify it into sort of constructive steps that you can do as an individual on the ground level. I think ERAS is really the analogy that keeps giving. Everyone likes to align everything with ERAS. And I think this isn't too different in that this is a bundle of care with very clear steps. I'll show you in a second, 3 very clear steps that need to happen in order for shared decision-making to occur. And I think, again, like ERAS, it's one of those things where we all like to think we do shared decision-making, and I think in reality, actually none of us are really doing it properly. But I think if you distill down the literature and the documentation, the policy guidelines we have about shared decision-making, I think we can make it simple so that there are steps we can actually do to get closer to this ideal goal of truly achieving shared decision-making. And so this is what I've sort of come up with. This is not, anything revolutionary. It's just what I've come up with to sort of distill some of that model down, some of those words down into pictures, because I think a lot of us operate better on pictures. And it really relates also to, I don't know if many of you have done any communication skills work, but this idea of disease and illness. And overall, the literature tends to refer to this kind of concept as the 2-expert model. And the 2-expert model really recognises that the patient and the clinician both bring different but equally valid expertise to the decision-making process. So in this scenario, the medical team are the experts on the disease. So, as a anaesthetist, pathologist, radiation oncologist, surgeon, you name it, all of you have expertise in the appropriate medically feasible treatment options. So you can come up with what are the appropriate things you can offer a patient. And then in return, the patient is the expert on the illness. And illness is different from disease because the disease is what happens to the body, and the illness is what happens to the patient because of the disease. Okay, and they're subtly different, but they're very, very importantly different. And so they will share with the team what their story is, what their personal story is, and how this has influenced the values and beliefs that they want the medical team to base any medical decisions that are made on. And the last kind of key of this equation is the recommendation. And I'm very strongly of the feeling that it is not enough as a clinician for you to simply put the options out there and expect a patient to choose. That's really not fair of us. A patient, unless they've been very well versed in sort of medical complications or medical situations, they cannot possibly be in a situation where they have the same knowledge as you, where they can make a decision. And so I think it's really sort of important for us as clinicians to be able to be strong enough or brave enough to make a recommendation. But the big caveat to this is that the recommendation has to be based on the patient's values and beliefs. So making a recommendation is not a return to that old paternalistic way of medicine. It actually behoves you more to understand where the patient is coming from and what their values and beliefs are so that you can make a recommendation not for what you would do if you were in that patient situation, but what the patient should do based on what they've told you about themselves. I'm just going to pause there because I think that's a really important point to take in. So I always get asked what is the actual evidence behind shared decision-making, and a lot of you will probably have looked at the previous slide and realised that there is nothing new about shared decision-making, and ultimately it's really just good medicine. It's what we should be doing as good doctors who respect our patients. And to be honest, the evidence behind shared decision-making is actually exceptionally limited. There's a huge body of evidence to say that patients prefer this, and this obviously links in with Charlie's work to say that patients want to be, and almost now as we're coming into this baby boomer generation, will expect to be involved in decisions made about their care. But actually, there's minimal evidence linking measures of shared decision-making to improved health outcomes. And I think that it's important to reflect on this because I don't think that there's no evidence because there isn't a connection between shared decision-making and better health outcomes. I think that there are probably two factors that we haven't taken into account here. And the first and probably most important one is that we don't know how to measure shared decision-making. We don't know what the right outcome is. Okay, and when we look at presentations that people do on things like CPET and nutrition and exercise prehab and all these sorts of things, and everyone talks about morbidity and mortality outcomes, functional outcomes, even sort of patient satisfaction scores. And all of these traditional outcome measures cannot be applied to shared decision making, because we know that people in the same situation will make different choices based on their personal story, their background, what has happened to them, and how risk-averse or cautious they are. And so we can't tie things like even functional outcome or patient satisfaction to shared decision-making, because if you're a fighter pilot and that was your background, you're obviously very pro-risk. You're happy to accept risk for the chance of a successful outcome. Whereas if you're an accountant, perhaps, you might be very risk-adverse and be unwilling to take risk even for the small possibility of a successful outcome. And so you cannot link the success of a patient's treatment journey to whether shared decision-making has happened. It really has to be an end upon itself. And just because someone chooses to have an operation or not to have an operation, and they do badly after that, and their quality of life is significantly worse, it doesn't mean that shared decision-making didn't take place. They don't have to take you up on their recommendation. It's the fact that they made their own decision from a list of viable treatment options. That's the important thing. And the second thing that I wanted to refer to about why there possibly isn't a good evidence linking it is that we actually don't know what patients need in order to feel that shared decision-making has taken place. So how do you actually work out whether it did happen or it didn't happen in order to link it to an outcome, which we don't know? And the problem is that the studies that are out there have used things like observed sort of independent observer tick boxes for whether shared decision-making took place based on a list of sort of priorities that you need to do to have shared decision-making. They've also done direct reports. Most of the studies are direct reports of patients saying whether they feel like shared decision-making happened. But the problem with that is that what do patients actually think shared decision-making is? And I think a lot of them don't actually really understand what it is. And it may be that your experience of shared decision-making is good because you liked your clinician, or because they were a good communicator, or because they told you the information you wanted to hear. And maybe, all those sorts of things mean that we don't really know how to measure it or how to know that it's occurred. So at the moment, although there's a lot of work to be done in this area, the real kind of reason to keep going with shared decision-making until we get that final evidence is really this statement that comes from the King's Fund paper again, which is that the most important reason for practicing shared decision-making is that it's the right thing to do, and that there's an ethical imperative that we as clinicians need to serve our patients in order to make sure that they achieve the best outcomes that are most appropriate for them. And I think all of this, even though I said that we don't have good outcome measures at the moment, I think all of this is really coming back to trying to prevent this phenomenon called decisional regret. And I think that's what we're all really focused on, which is how do we stop patients from saying, 2, 3, 5, 6, 12 months down the track, if I'd known that this is what having surgery meant, or had I known that I was going to end up in intensive care for a month, or had I known I was going to get a tracheostomy, I wouldn't have gone through with that. And this is a very good paper. It's about 73 papers conglomerated together that looked at decisional regret, primarily from a patient point of view, but there were a couple of studies that looked at surgeons' regret as well at taking on surgery. And it's quite a shocking paper in that they looked at sort of half oncology-based surgeries and half non-oncology-based surgeries. And 14% or 1 in 7 patients regretted having surgery in the non-oncology situation, and in the oncology situation that rose to 18%, so almost 1 in 5 patients. And we know that we do about 3 million surgeries in Australia a year. So if you extrapolate those numbers, there are over 500,000 patients who regret having surgery. And if we extrapolate that to a UK scenario where they do 10 million surgeries a year, that is over 3 million patients who regret having their surgery. And I think this is what shared decision-making is all about, because I think people, even if they have very bad outcomes from either having a procedure or not having a procedure, I think if they understand what they're in for and they were involved in that decision-making process, which is what this paper highlights here, that their preferred and their assumed decision-making roles were aligned, then they are willing to accept bad outcomes because they went into it with open eyes. And I think the other things that we get out of this sort of paper and other similar papers is the understanding that probably the reasons that oncology patients have these higher expressed levels of regret is probably that there is a closer link in their heads between surgery and cure. And I think we have an onus or a duty to separate that link in patients' understanding that surgery, although it may mean cure, may also not mean cure. And also cure and surgery don't necessarily align with getting better or a better functional outcome. And the final thing I wanted to sort of point out from this paper was this concept of, I think yesterday it was mentioned a couple of times, and I often hear this coming up when I talk, when I sort of are talking about this kind of area. And it's this idea of doing something versus nothing. I take a real umbrage with the phrase doing nothing, and I think that if any of you use this in your consultations with patients, that you should probably stop it, because there's a good body of evidence to say that patients, when they're confronted with something versus nothing, do not view that as a viable choice. They don't see that as a choice, because if you're saying do nothing, then obviously everyone is going to choose to do something. And the honest truth of the fact is, as a clinician or as a doctor, you never do nothing. You're just not offering a specific treatment. You're still caring for the patient. And what patients don't want to feel is abandoned. Patients never want to feel abandoned, and you aren't going to abandon them as a responsible clinician. You just shift the care from one focus to another. So you're still caring, you're still being an active carer and an active care provider, but you're shifting your goals from, say, surgery and cure to potentially symptom relief or another focus of the treatment journey. So why is it harder for us as surgeons or in the perioperative environment to do this? And it's because there aren't really any decision aids out there. So a lot of the evidence about shared decision making comes from things like breast cancer screening, prostate cancer screening, situations where there are very well-established risks. We know what the false positives and the false negatives of a PSA test are. We know what the population incidence of prostate cancer is. We know what the treatment options are for prostate cancer. These kinds of specific outcome data do not exist for surgery because every patient is different and every surgery is subtly different as well. And we can get things like NESQIT that can give us an overall picture, but the outcome data is much more ambiguous than in other situations where shared decision-making has been applied to. And also, outcomes are very uncertain. So, as Charlie mentioned, traditional outcome-specific advanced care plans where we really focused on these goals of care discussions about resuscitation and antibiotics and dialysis, and do you want life-sustaining versus life-prolonging treatment, are really not useful at all. And what we want to move towards, which I'll talk about later, is a values-based advanced care plan, which Charlie's My Values thing really highlights. And I don't know if any of you saw in the My Values slide that Charlie put up, the writing was quite small, but none of those questions are about specific treatments or specific sort of situations. They're more about how you feel overall about certain situations. And I think a lot of this is partly to do with the fact that it's very, very difficult because of the factors that I've mentioned for us to have effective risk discussions with patients about these things. And at the moment, a signed surgical consent form is really the only documentation we need as evidence to say that we have had these discussions with patients. And I think really informed consent in the perioperative period is a little bit of a myth. And so we often tell patients things like this. So we tell them, if your surgery doesn't go well, you're going to go to intensive care, you're going to be kept asleep, you're going to be kept on a breathing machine, And if your kidneys don't work, then we'll put you on a machine that's going to help support them. So this is what you tell them, and this is what they hear, this kind of sanitized version of exactly what's going to happen. What they don't hear is this kind of scenario. And this is not to say that this situation is neither good nor bad, but you will find a proportion of patients for which this is acceptable, but you will also find a proportion of patients for which this is an unacceptable situation. And the fact is that you can talk all you like about dialysis, but if a patient hasn't seen it before, then they cannot truly link their concept of risk in a grounded reality, unless they've had a father, brother, mother, sister who's been in this situation before. And I think that's why Charlie's work is so seminal and so, so groundbreaking, because it brings this picture to a real informed risk kind of discussion. So I'm going to move on and spend the last sort of section of the talk talking about how we've actually tried to implement it in Peter MacCallum. And really what we've done is taken the 3 steps that have come from the guidelines that I've shown you before, these sort of policy papers, and then tried to make them sort of grounded in our perioperative sort of services. And the first thing that we've done is obviously identify the patients that we feel would benefit from this situation, because obviously you can't do it for everyone. And these are our criteria, but obviously they're going to be different for your specific institution and your specific population, depending on what your needs are, so you will have to adapt them. So what I've taken here, you can see the Union Jack there. It's really to show that these are the 3 steps from the Union Jack paper, and these are sort of the things that we've taken from the paper and how we've tried to kind of extract the message. This is really just to show that the Americans have the same concept but different words. Again, it's still a 1, 2, 3 kind of thing, and it's outlined very nicely in this paper here. And so the first step is this idea of information gathering. So we still have the traditional surgical MDT, which you can see here on the left. This is the thing that pretty much all health services have well established. So this is where the surgeon, the oncologist, the radiation oncologist, pathologist, radiologists all get together and they work out, based on the pathology the patient is presenting with, are they a suitable candidate for surgery? Are there viable other options like radiation or chemotherapy or something else? We then take this information to a separate MDT, and this is a shared decision-making MDT, which involves some more of the perioperative medicine team. So the surgeon comes along as a representative of the first MDT that has happened, because they're the expert on the disease, and then that's also combined with experts on patient illness, so the anaesthetist, intensivist, physician, geriatrician, allied health, prehabilitation, exercise physiologist, palliative care if that's appropriate. And it's there where you define the feasible treatment options, because one of the big caveats of shared decision making is that there must be treatment clinical equipoise. And what that means, it's a lot of big words to essentially say there has to be more than one viable option. So I don't know if any of you were in the session yesterday where a question was asked to one of the surgeons, how do you feel about doing futile surgery? And I think one of the kind of key things about that is if you truly believe a surgery is futile, it should never have gotten past the first step. It's not a viable treatment option because there isn't clinical equipoise between doing the surgery and conservative treatment. So there must be those two sort of viable options there. And that's what this MDT is about, is really distilling down what are the options that we're going to present to the patient. And the reason we do it as an MDT is I think we all know that as perioperative medicine specialists, as we move into sort of these subspecialty areas, we all have one piece of the puzzle. The exercise physiologist knows about prehabilitation and whether they can access appropriate physio services in their regional location. The surgeon knows about the surgical approach. The anaesthetists and the physicians know about frailty. All of these things come together, and it's really not until you come together and bring all these things in one particular location and one discussion that you can really get this idea of how the patient is as a whole and how this is going to impact on your recommendation to the patient. Because remember, in the end, it's all about making an appropriate recommendation. So the second part is now where we exchange the information with the patient. And in this bit, there's going to be two people sharing. So remember the initial equation. There's going to be a doctor sharing something, and there's going to be a patient sharing something. So the doctor's going to share all the stuff that you would expect a doctor to do, which is really that you're going to talk about an individualised risk profile. So looking at things like, NESQIP, looking at things like best case, worst case kind of scenarios, natural history of the disease, and then the shared concerns from each specialty area. So why are you going through this process? Why are we as a perioperative medicine team concerned about how you're going to do after surgery? And then discuss the potential options and the course for each of those. So we always tend to, as humans, we like to focus on the positive. So we like to talk about the things with patients that are easy to talk about and then skim over the nasty negative details. But if you're doing a truly informed risk discussion, you have to present the parts as being equally important. So you have to take the time to talk about what's going to happen, what is your likely scenario going to be if you have surgery, what is your likely scenario going to be if you don't have surgery and you opt for a different kind of treatment. In return, the patient is going to share with you the illness part of the model. So how has the disease impacted their life? What are their fears and hopes for the future? And what are their unacceptable outcomes? And Charlie referred to this as well, but there's a good paper, which I haven't actually included in here, that talks about states worse than death. And there's been a very good population survey to show that there are several states that ill patients will consider significantly worse than death. And this idea, again, of linking that then with what degree of risk are you as an individual willing to take? Are you a fighter pilot or are you an accountant? Where on this risk accepting spectrum do you exist? And I think really this is where perioperative advanced care planning sits, moving away from that traditional specific context advanced care plan to a values-based advanced care plan that's going to help medical decision making be productive for patients. So this is what this is all about. So I don't put that much emphasis when I talk to patients about advanced care planning about specific resuscitation orders and things like that. I really just want to get their values, because as a clinician we can generally make the medical decisions about resuscitation and treatment if we know the values-based part of the equation. The other bit's relatively easy most of the time. And so then we put all those bits together and we come up with a recommendation that we then offer the patient based on the initial MDT, the shared decision-making MDT, and then the exchange of information between the patient and the care team. And then this idea that it needs to be documented somewhere and it needs to be reviewed regularly. And electronic medical records will make this easier. So there's a lot of talking that I've done, but really this kind of pictogram does summarise what we're trying to do. And you can see here that really the first step is this shared decision-making MDT, where you're refining down what are the treatment options and you're ruling out things that aren't beneficial. So if things are futile, then they're not offered to the patient. You don't even raise it as a sort of an option to the patient. And then you align that with the information that you get from a shared decision-making clinic appointment or an advanced care plan, which are the goals and what's important to the patient. And these are then combined to make a recommendation that is fed back to the patient. So you recommend what you think they would want, but of course the final decision then is left up to the patient to determine. So that's really it in a nutshell. And I think you'll see that going back to our original policy statement, there are 3 steps. And you can see here that we've really managed to, I think, really translate these 3 steps into kind of a practical approach that you can hopefully embed within a perioperative service within most kind of institutions. So that's sort of the work we've been doing. And, I have distilled it down as easy as 1, 2, 3, but Jackson 5 references aside, it's not easy. And I think that's the crux of it, is that everyone wants to put everything down to shared decision-making, and it's this one-liner where we say do shared decision-making, but actually there's so much more to it than that, and it requires time and commitment and skill. But I hope you can see after all of that it is worth it. There's a significant reduction, we hope, in decisional burden by both families and clinicians. It stops those conversations at 2 o'clock in the morning, hopefully, from happening when the ICU team get called about a MET call and an unexpected HDU admission. And hopefully it'll recognise that there is an individual behind the patient, that there is more to medical decisions than just medicine. And so I think, as I mentioned or alluded to earlier, there are a lot of frontiers that we really need to explore in shared decision making. And I think now that we've got the interest, this is the time that we're really going to hopefully be able to explore some of these issues. And I think the two big next frontiers that we're going to need to combat as sort of perioperative clinicians is how do we engage patients? And I think Charlie's obviously had one, amazing way to do that. I've been working on a project with the Royal College of Anaesthetists, their perioperative medicine SIG, and they've got a very good video about perioperative medicine, and I'm now producing one about shared decision making. So hopefully this video will be ready by the end of the year, and we're hoping to embed that and play that to all patients in a pre-anaesthetic clinic to really give patients a better idea of what shared decision making is and to promote them being involved in decisions. And I think the other big next step is going to be upskilling and communication. So if you think about communication as a procedure, there are very good studies to say that an average clinician over their career will do 150,000 clinical consultations with a patient. And it may be more for someone like an anaesthetist. And if you, again, like I said, think about communication as a procedure, it is the procedure that you will do most in your entire career, more than arterial lines, more than cannulas. You will do communication, and we don't really upskill in that. And I think there's now a national imperative to improve our skills as communicators, as clinicians, and that's been outlined in the new standards for the Australian Commission on Safety and Quality in Healthcare. So I think that's where we're heading, increasing our skills to be able to deliver frontline shared decision making. And as a result, we at Peter MacCallum are going to be holding a shared decision making workshop next February, which Charlie and I will both be presenting at. So if you're interested there, you can email us and get involved with that. There are also, I will mention, several other similar courses that do other things. I think ours might be the only one with a perioperative focus, but there are several very good courses run by the Cancer Council that look at communication skills and shared decision making. So I think that's where we're going to leave it for today, but I hope that you'll see that shared decision making isn't easy, but it truly is well worth it. And that we're only at the sort of the frontier of this era of new values-based, patient-centred decision-making, and it's an exciting area to be in. Thank you.
Top Med Talk.
Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com, and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.